How to treat refractory hypoalbuminemia? So massive proteinuria, as you see, nephrotic syndrome and few other illnesses, CLD, malnutrition, and few more. So they have at times, especially in children with resistant nephrotic syndrome and congenital and infantile nephrotic syndrome, you have very difficult sort of proteinuria, massive proteinuria for days together, months, weeks together. It's very difficult situation. You have in those cases more than 1 gram per square meter per day, 2 gram, 3 gram, even higher, more than 4 gram. Very severe sort of proteinuria. You good amount of time, you have concomitant hypoalbuminemia. Less than 1 gram is common. More than zero point 0.5 gram is also possible in severe cases. In those cases, you first take the BP and see whether patient is hypovolemic or not, and take the other measures and other investigations to diagnose hypovolemia. The point of care ultrasound, urinary sodium, and so forth. Clinical, then just sunken eyes, depressed fontanelli in younger kids, and your pulse, blood pressure. And you give albumin infusion 1 to 2.5 to 1 gram is more common. The used albumin level, dose like at times you need to give more 2 gram per dose per shot. In severe cases you can go higher up to 4 gram. In CNS congenital nephrotic syndrome you give, and then you see the volume, you see the blood pressure. If they are normal, you wait. If they are still on the lower side, you go on giving it, and a good amount of time you have a normalized situation, so you can give little bit of furosemide along with it, zero point 0.5 to 1 gram per 1 milligram per kg. Highest you can go up to 4, but usually in the lower side, because higher amount of furosemide may push the child again to your hypovolemia and there the renal impairment. And if the renal impairment is there, creatinine is raised, you have hypovolemia, you have prerenal AKI. Make sure that you are not missing the renal and postrenal AKI. They are though unlikely. And triggering events of AKI like sepsis, nephrotic syndrome, and other illnesses, and your other triggering events, hypervolemic, and so forth, they are to be addressed, and then see patient is stabilized. You treat the triggering events, like for example, pneumonia, sepsis. You give him 1 and 2 antibiotic, whatever, and other supportive case. So immunosuppression to stop proteinuria is to start when the infection is a little bit reduced. So and then you go on giving albumin infusion. Usually, these measures the immunosuppression, treatment of infection and asthma, and concomitant other comorbidities. You have at one stage of the patient care, you will be able to go for the lower sort of albumin at one stage. Good amount of cases, most of the cases in whatever the disease like, you will have a stage where you can reduce the albumin dose in infusion, and at times you can quit the albumin infusion when the disease is responsive. When the disease is reversed, not responsive, you may have need to continue it for longer time.